Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is chronic asthma. So, what is asthma? This is a reversible airway obstruction associated with inflammation and bronchial hyperresponsiveness due to various local stimuli, including histamine, leukotrienes, and prostaglandins. It's very likely that all of you watching this video have had some experience, at least, in treating someone with asthma, either acutely or in outpatient clinics. Asthma affects 15% of the adult UK population, so it's not an uncommon condition. It also accounts for 1,500 deaths per year in the UK. As you can see, there are quite a lot of risk factors for developing asthma and also triggering an attack. So these range from genetic predisposition and a family history of atopy being the triad of eczema, asthma, and allergies, as well as environmental exposures to air pollution and house dust mites and pollen. And then there are also occupational exposures, as well as other factors such as exercise-induced asthma and cigarette smoking. It's also really important to remember adherence and failure to comply with medications, which can also trigger asthma attacks. Symptoms of asthma are pretty much self-explanatory, but include breathlessness, chest tightness, wheeze, cough, and sputum production. Symptoms are also typically worse at night. Patients may be tachypnic, and in addition to having a wheeze, there may be evidence of hyperinflation. There may be evidence of atopy in terms of eczema or eczematous rashes. And there may also be evidence of nasal polyps, particularly in people who have aspirin-sensitive asthma. The diagnosis of asthma is clinical. However, in order to aid the diagnosis, there are several investigations that do need to be carried out. The most important of these is a peak expiratory flow rate, or PEFR diary. This can help to pick up occupational exposures which may be triggering attacks. Spirometry with histamine or methacholine challenge is used to assess airway responsiveness, and phenotesting is also important in the diagnosis of asthma. History and examination is key for the diagnosis, as well as a baseline set of observations. Blood tests can be important, particularly to look for a high eosinophil count. The chest X-ray may show evidence of hyperexpansion. Serial peak flows and a diary are useful, as well as spirometry with reversibility, as we've just mentioned. Phenotesting is also important, and skin prick tests may be done to check for additional allergens. The treatment of asthma aims to reduce exacerbations, reduce limitation of physical activity, reduce the need for a reliever, such as salbutamol, and reduce symptom variability between the day and night. There's also the aim of maintaining normal lung function. On this slide, this shows the BTS sign guidelines for escalation of asthma therapy. So you can see it starts with initiation of treatment with low-dose inhaled corticosteroids, which can then be increased to adding on a long-acting beta agonist, in addition to the ICS, and then further therapies can be considered depending on the level of control. There are several biologic therapies which are now available for the treatment of asthma. These involve IL-5 or IgE inhibition. Omalizumab is an anti-IgE biologic, and then there is mepolizumab, resilizumab, and benralizumab, which block either IL-5 or its receptor. Omalizumab is indicated for severe allergic asthma, while the other three are indicated for severe eosinophilic asthma. Long-term management also involves avoiding triggers, such as the ones we listed previously, as well as smoking cessation. So let's try a couple of questions. A 23-year-old patient presents to his GP with a 6-month history of intermittent dry cough with associated breathlessness and wheeze. He has noted these symptoms are worse when he is at work in the local factory. The GP suspects a diagnosis of occupational asthma. What is the most appropriate first-line investigation to help with the diagnosis? So our options are chest X-ray, peak flow diary, skin prick testing, bronchoscopy, or spirometry. Now, you'll remember when we discussed this that the peak flow diary is really important when first making a diagnosis of asthma, particularly when an occupational exposure is thought to be the trigger. So B is the correct answer. Question 2. A 28-year-old female with difficult-to-treat asthma has been sent to the tertiary asthma clinic for consideration of initiation of biologic. The consultant chest physician decides to start the patient on omalizumab. What is the mechanism of action of omalizumab? So our options are anti-IL-5 receptor, anti-IL-5, anti-IgE, anti-TNF, or anti-IL-6. So you'll remember, hopefully, that omalizumab is an anti-IgE drug. The other 3 biologics which are licensed for asthma are either blockers of the IL-5 receptor or IL-5 itself. Anti-TNF and anti-IL-6 drugs are not used in the treatment of asthma. Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.